Hello, nurses. This is Kevin with Nursing KAMP.com, and these are my scribble notes on nursing in the NCLEX. Today's focus is going to be on the sticky note, oh, not that one, called Afterload, After the Heart, and Hemodynamics. Please see my lecture on normal hemodynamic measurements, where I cover CVP, cardiac output, wedges, and ejection fractions. This is the abnormal process of after the heart. Please also see my preload lecture where I talk about preload before the heart. Preload, be the load before the heart. All right, so what's the problem with afterload? So it's after the heart and it's out in the body, right? So it's out in the body in the fingers and toes in the vasculature. So there's a problem out there. And when we're looking at that problem, what is that problem? Well, if there's a decreased afterload, and I always think of these kind of trucks when we're looking at of volume, okay? And sometimes what can cause this is vasodilation when there's a decreased afterload. So again, the same medications that we treat preload, like lasix and nitro, they can also affect vasodilation. But more importantly, we're talking about systemic vascular resistance. So that equals the tension out in the peripheral system. That's the SVR. And SVR is anywhere from 700 to 1600. So if there's increased tension, more contraction, then it's higher. Less equals lower. See my SVR lecture where I go over that a little bit more clearer. Okay, so let's talk about decreased afterload. Well, it's same thing like on decreased preload. Is the problem is that there's not enough fluid or it's vasodilated. Well, the first thing is that you're going to have decreased urinary output. And when you have decreased urinary output, the kidney labs will increase. So the BUN, no problem with the BUN and creatinine will be elevated. And, whoops, losing a little bit there. And, okay, sorry about that. Okay, so the BUN and creatinine will be elevated. BUN more specifically, then the creatinine also be elevated. In an acute situation, both are elevated. However, if they're just dry, BUN will only be elevated, not the creatinine. Okay, so decreased urinary output, less than 30 cc's an hour. What's some of the causes of this? Well, the big causes are, like we said before, medications, over medications of bumex, lasix, vasodilators will decrease this afterload. But sometimes to expect that it actually causes a decreased volume. And then they, sorry about that, then they start to have decreased perfusion. And as we said before, we would monitor the blood pressure. And blood pressure would be affected. The mean arterial pressure would be less than 60, 65. And that's important because that's needed for the kidneys to be creating urine. Also, mean arterial pressure needs to be 70, 75 for the brain. And if you don't get that, you have decreased level of consciousness. That's why restlessness, decreased level of consciousness is always acute with mean and first to be going before urine. Okay, next is what's some hemodynamic measurements? Well, the CVP will be less than 4. Okay, CVP. You see the volume peripherally. See my CVP lecture. If it's less than 4, they're dry. Okay, and wedge pressure, PAWP, which is normally, let me see, this is 4 to 8. We add those together, that's 8 to 12. Wedge pressure is left atrial volume, fluid. And if it will be less than 8 because we have a decreased amount of volume going on here. Some general causes are mitral regurg because on the left side of the heart. Okay, and then what else? And some left ventricle hypertrophy. So big trophy hearts. So that means it's such a big tissue there's not enough space to give fluid there. And so it causes a problem output-wise. Next is increased afterload. Now, increased afterload is a little bit different because there's vasoconstriction. They're over-squeezed, alpha. Squeeze. Alpha upside down is vasoconstriction. See my alpha medication lab lecture on that. So an increased afterload, there's vasoconstriction going on, as evidenced by here. And signs and symptoms are still the same. Decreased level of consciousness. They're going to have syncopal episodes, so they'll fall on their face. So, like I said before, with preload, it's the same thing in a sense, just different locations. Some problems with causes is aortic stenosis on the left side of the heart. The volume stenosis, if it can't get out, it increases this afterload, causing more pressure. All right, some other causes are CHF, obviously. CHF. Atherosclerosis. Atherosclerosis, because remember, the fingers in the peripheral vascular disease, the fingers and toes, the space is smaller. So it's very small because of sclerosis. And that causes vasoconstriction, and then it causes the heart having to press and increase its amount of pressure to get out through this. Think of like kind of blowing air through a straw. Can't quite get it through. So that means it's increasing its afterload. It's trying to overcome this tension. Next is a history of rheumatic fever and valvular disorders like chronic congenital. All right, so increased afterload, what do we do to treat it? Well, nitro proside, so that will vasodilate things in the peripheral vascular system. Nitrates, vasodilators, mainly for medications. And for decreased afterload, we do the direct opposite. We use vasopressors. So on decreased afterload, where there's this vasodilation, we're going to squeeze vasopressors like epinephrine, neosynephrine, and dopamine. Please see my epinephrine, dopamine lecture where I talk about alpha medications and vasopressors and those types of things. Okay, so normal hemodynamics and generally CVP is 4 to 8 and wedge pressure is 8 to 12. And cardiac output should be 4 to 8. However, with a decreased afterload, it's going to be less than 4. The reason is because there's not enough fluid involved. So afterload and preload are conceptual models where we kind of look at preloads before the heart, so the medications that affect the fluid coming into the heart, by slowing it in or affecting the volume, like beta blockers, diuretics, and morphine, nitrates. These things restrict the flow coming in, and most likely on the right side, like tricuspid problems or AFib. It's different with the pulmonic valve because the right side causes tension in the lungs, forcing the fluid to build up on the right side. However, afterload is after the heart, so we generally treat the tension after the heart to allow the heart not to work so hard and resulting, because if we don't do it, it results in hypertrophy and further complications. Nitro and nitroprusside along with calcium channel blockers all work on afterload of the heart by vasodilating or relaxing the vascular bed. I always think of calcium's hard and it softens these vessels out, so they tend not to have as much tension, so therefore that treats an increased afterload. Well, my name is Kamp, and this is Nursing Kamp. I can be found on social media, Instagram, Facebook, Pinterest, Nursing Kamp, and also I'm on Etsy as well. Visit my shop if you like. Say hello, make comments, and see me on nursingkamp.com. That's it for this lecture. I'm going to cover cardiac output in my next lecture. So check back and nurse on.